Okay, well, and just for clarification purposes, what we've tried to do is take advantage of our panelists here. So we're going to prioritize questions for the panel. If you've submitted a question, that's a Palmetto GBA question, we'll take that towards the end. If we don't get to it, then we'll do an FAQ and send it out as part of the package when you get the slides, okay? This one is for Spartanburg. And I guess Carla? I know the answer to this because I was told the answer, but would Spartanburg be willing to share the CME presentation?
Yes.
Okay. So that's a positive, right? Okay, very good. Chris, how/what does your plan of care look like with face-to-face event or statement on it?
Yeah, someone asked that over lunch. Where on the 45 did we put that? And we had a discussion about that, and there were three options that were discussed in our agency. One was putting it somewhere in box 21. One was adding it somewhere in the certification statement, and one was in the clinical summary section at the end. And we've tried a few different things, and we haven't finalized our decision, but the clinical summary seems to be the best place for us with our system. It's easy to edit, so in QA is doing that final review before it's sent to the physician. It can easily be added in that clinical summary section.
Okay. I have one for Bud. Bud, do you get pushback from physicians regarding using the portal connections?
Yes. We do get a lot of pushback. What we try to do is target the higher volume physicians who are more technically inclined. So there are some physicians who'd like access to a portal. There are physicians who don't. So we have the conversation once, and if it's an adamant no, then we move on. But we've been able to incrementally grow the percentage of our higher volume physicians that are using the portal, and that's given us a whole lot of efficiencies, including better accuracy on the documentation we're seeking from them. It also helps kind of keep them as a referral source that's loyal to us because they get used to the system. So there's always a lot of pushback. There's always pushback to change, but that doesn't mean that we stop pushing them.
So even though that question was directed to Bud, if anybody, for any of these questions, anyone on the panel can also add on or jump in. No?
Bud, how's that going to fit with your tie-in now with Forcura and the because isn't Home Care Home Base tied with Forcura now? It's a company that handles all the, they coalesce all of your faxing and all that stuff. So I guess you're
So make no mistake that I have no role in Home Care Home Base. I don't know where that's going from that side, but today the portals are still up and active, and we're still using them to the best of our ability. It's a great question.
And Kimber can help you out.
Kimber can help you.
Right now, I think Forcura is an add-on thing for was just at the conference recently, and Home Care Home Base. One of the I'll sell for you just a little bit, okay? I know, I looked for you. Home Care Home Base does a really nice job of looking at other vendors to help support some of the work that we do if we don't necessarily buy into every one of the opportunities that are part of the system. And Forcura is just another vendor that is aligning with them to do a lot of things with them that we have an opportunity to look at and see if that's where we want to partner. So I don't know that it's necessarily something that is going to be part of their system as it is another vendor and another option for us as providers to use. We're looking at it too, by the way.
Okay, and this one's a free-for-all. This is a wild card question. Does anyone have a face-to-face process in the ER?
Potentially. So, we have added, one of the things that we did with our pilot project is we rolled into a role of a post-acute navigator. And so we do get calls from the ER, and that's a huge learning curve for documentation. And so we'll probably haul Dr. Snipes the next time that happens if he's available, because he has a way of talking to ER physicians. So potentially.
Okay.
So, Carla, when we were out on the listening tour, hello, didn't we have one of the case managers to talk to us about she was designing the process where she was training the ER docs?
Yes, yes, you're right. We on the listening tour, one of the case managers that we've met, and she's really excited because we developed that what she was asking for her physicians was a rapid referral form, which is something one of the competitors was doing that did contain the face-to-face elements, and that they complete it even during. So if the navigator is off, is not able to come see the patient face-to-face and interview them at the same time all this referral is happening, they can complete a form and fax it over to the home care agency that the physician is willing to sign at that moment. And so that is active, and she was the one that actually brought that up because she carries the ER caseload for those. So, yes.
Okay. And again, this is a question for everyone. Well, what EHR system do you use?
Caroline's Healthcare Physician Network, or the Clinic Network, as well as the hospital system, is currently using Cerner.
UF Health uses Epic for clinics and acute care facilities. Home care uses Delta Health Technologies.
Healthy at Home uses Home Care Home Base.
Our home care uses McKesson, or
Home care, home base.
And the following question is, would you recommend this process to others?
Without reservation. Yeah.
Okay. Okay, this one's for Kimber or Carla. Have you made any headway with hospitalists/residents?
Yes, I think so. And Linda Edmonds is actually in the back of the room. She's our population health manager. I and Dr. Snipes went and met with that group, so I'll speak about ours first. They were very receptive. We have made a lot of headway from when we initially did our listening tour, which was really fun. And so they have been very receptive and very amenable to doing, and they actually are the ones that requested the pocket card, and it's kind of funny to see them use it all the time because they have lots of things in their pocket. But they use that in dictation and are beginning to use it on a day. So that helps everyone in home care, not just our home care agency.
No. And actually, it's a group that we haven't really even addressed yet. We still have 1,000+ ambulatory physicians. that we are addressing and working with. We have gotten, if I can say this, we have made great headway with that group, even though there's, a bunch of them. By having this process, we've been able to raise the level of awareness to the point that we are working directly with 2 of the ambulatory physician leaders, one in the family practice area and one in the internal medicine area. And what we have found, which is amazing to me, is that there's these secret meetings that only they know about. And they have actually shared with us what those meetings are, what are the most important meetings if you want to get to those physicians, what are those meetings? And we have made it to the agenda of the meeting that if you get to the agenda, all of those physician leaders will actually pay attention because you're on the agenda. So next week, we will have the opportunity, and it will be physician to physician, talking to other physician leaders about why we get 15 minutes, which is actually quite a lot. 15 minutes to talk about why face-to-face is important, what briefly we're doing about face-to-face in terms of making it easier for them. And our request is that they go back to their practices and let them know that we will be knocking on their door and we'll need time in their offices to talk to them about the process. So then the running begins as we go around to all of these different practices and talk to them. But I think that we will, after that, we will then start focusing on the hospitalists. But I'm feeling really good about that. I think that is the first time ever anyone outside that group even knew there was such a meeting. So.
Thanks, Kimber. What is the biggest benefit you gained from the pilot? If you have to choose one, what was the biggest benefit?
I guess for me, being from the practice side, the biggest piece was understanding what home care did. I knew what they did. They provided services in the home, but what it took to get them there and actually understanding in real English, my English, what the requirements were and what role I played in them getting paid or my patients getting the care that they needed.
I would say for me, the biggest thing was having everybody at the table, because until we all got in that room together, we had been living in our own little worlds, and actually having everyone together made the process work because we were able to talk it out and say, that's doable, that's not doable, this is why we need it, for other areas to realize why we need the information we need, because they just really thought we were just bothering them, I think, some days. So having everyone together really makes the process go forward a lot more smoothly.
I agree with that. I think having everyone together and discovering that silos are not useful and workarounds sometimes can create more work was a huge benefit. But also seeing the physician perspective for Spartanburg was huge, because what we were, interestingly enough, and I'm surprised Kathy and Annette have not already said that, but we had a process where if they did not respond in a certain amount of time, our medical records department came out with a punitive response, which was a certified letter, and that did not go over well. And so that was a great learning opportunity, and when we've used that to learn how we could possibly change our practice. So.
I think for us, it was eliminating waste and getting the efficiencies in our billing process. So that certainly has paid dividends for us. And just a better understanding into our own processes and how we can sit down and map out future processes and other processes the same way. So we've actually taken the same steps and applied them in a couple of other areas as part of our QAPI program and just internal reviews. So just the process in and of itself was a great benefit to us.
Honestly, I don't know if I can put one, above the list. That I think all of us had a slide full of benefits. So it's really hard to pick one, but I would have to agree with bringing everybody together. And Annette and Kathy, I think, witnessed in most of the groups that we went to meet with, most didn't really want to be there at first. They came in, sat down with their arms crossed, but once they started listening and understanding what we were doing, they opened up. And then they started throwing out ideas. And then they started to see how it could benefit them and make their workflow easier. So that was a big benefit.
And I just want to add that it wasn't just having everybody, it was having the people who do the work there. Because I think a lot of the time, some of the mess we started with was that we had leaders, myself included, who came up with a brilliant idea that when we asked people to do it, it didn't work, or they were doing the best they could with a process that hadn't been well thought out or considered other areas. And by having the people who actually have to touch it and have to do it and have to shred it, which I will never get over that. I will go to my grave with that one. But having the people who actually have to deal with it was so incredibly important. Because then not only did we get real information, but they were also the people who afterwards, and I'm sure this was true in all of yours, were able to go back to the same people that they work with to say, no, really, this time I think we got it. This time I think we really came up with an answer.
Okay, this one's for Bud. Can you tell us more about ICF?
Oh, yeah. So how much time do we have? ICF is the International Classification of Functioning. It's a product of the World Health Organization, just as ICD 9 and 10. ICD is the WHO's attempt to classify the causes for death, and ICF is the WHO's attempt to classify health. And so in the International Classification of Functioning, you're actually categorizing a patient's body function and body structure impairments that impair their ability to function in their environment and participate in social life. So it's a perfect complement for ICD-10 especially, but it's a perfect way to illustrate the homebound status and medical necessity in home health. Hospice as well. I think some people in the room use it for hospice as well. So I think it's a terrific tool. If you look at any nursing literature or therapy literature today, pretty much every article that you find uses the ICF to study outcomes. And if you don't know where to go find information about it, I'd be happy to share that with anybody if you give me your email. But it's been a great tool for us. I will say this too. We changed our ADR approach 2 years ago to every ADR that goes out of our medical review team's hands goes in with a cover letter that summarizes the clinical episode in ICF terms. And we saw our initial denial rate go down, our initial paid rate go up after we made that change, because it perfectly explains what's happening in the medical record and why this patient needed to be on service. So we saw that, which was successful. We've got a hand up, if that's okay.
Who creates that summary for you?
I'm sorry?
Who creates that summary for you?
People on my team, medical review consultants on my team.
Okay, I have a question for, I guess it's everybody. Are you a cost center or a profit center? And what are issues being cost centers?
I'm a cost center, but I do my best to contribute to the bottom line through all the activities that I participate in that contribute to value. So either through increasing quality or through decreasing cost.
Does ditto count? we're a cost center, but we definitely contribute to the value-based, and will more so. Every home care agency will in the future. I think we are all at an exciting time in healthcare where you're going to see it shift, and maybe we'll be telling people about how great it was. I don't know, but we're definitely a cost center, but we definitely contribute to the value of the system that we belong to.
Being an LLC, we are supposed to be a profit center. Supposed to be. We actually are allocated costs from the hospital, and we lose a lot of money every year. So, but being an LLC, it was originally designed to be a profit center.
Historically, we've been a loss, but over the last 5 or 6 years, we've pretty much broken even, and actually the last 1 or 2 years made a little bit of a profit, and that's excluding the value to the system. So,
Which you never get credit for.
we used to, but not anymore.
As a clinic practice, we are a cost center, owned by the hospital, and I don't make money.
Okay, everybody answer that one? All right. This one, what they threw was a curveball. This one's for the process engineers. All pilots were large agencies with multiple staff. How can this be implemented for agencies with under 100 or less patients?
We've got to share our microphone.
I thought we were best buds.
I think
What
it's,
happened?
I think
Bud?
it's bad cop day.
I think Kathy and I would both answer that the process is very scalable. So it doesn't matter if we're coming into a nationwide large system or coming into a very small system. And what was the number that was used, Harry? 100. I think it's very scalable, could even, go smaller than that. It's a matter of over the 3-week period. Initially we do that 3-week phase of here's baseline, then understanding the problems, and then coming up with the solutions. And then we have about a 5-week period of helping you begin to work the initiatives. So again, we would simply size it to whatever the organization is and look at how we selectively would get the right people who are hands-on into the process. And I think everybody here would probably testify to, as we went through the process, we were very, very understanding of how do we do this process, make it successful, but make it as least intrusive as possible. So for example, we went one-on-one with physicians. We met case managers in hallways. We met case managers in their little cubbies while they were working their process. We understood that life goes on, business happens. You're going to move the patient through the system. So we had a lot of flexibility in getting everybody that we needed into the room to be cross-functional. But I think it's very scalable. Anything else, Kathy? Right, that's true. And why don't you tell them why you had a soft site?
So trust. Trust is hard. So for our first session, we had them offsite in a hotel.
That was actually my question, because I represent a state association, and probably 50% of our members are very small providers. And it would be lovely to have all of you in a room, but some of our leaders are still making visits, and that was the question. I mean, they're out seeing patients.
Yes.
So that was the
Yeah,
question.
we're totally capable of,
And
designing
can
a
you
process
give
for
us
that.
the cost of your, do you charge?
Yes, we do.
And that was one of the offerings that we did initially with this project, was to say that Palmetto GBA would pick up the costs of the process engineers, in order to get the proof of concept, right? And there are other initiatives that we're also working on and thinking about launching. So as we approach newer initiatives, we're asking CMS to help us pay for that. But for initiatives like this, which we've already proved out that it has a return, we would expect that there be a contribution from the home health side.
So one of the things that Kathy and I would do is, whatever the size of the system, if somebody has an interest, we're more than willing to talk with you. And we always pull together a project and do an ROI for you. So you'll have total understanding for, the size of your organization, what should you expect in a return. So if that would help.
And I think it's important also to point out that both Kathy and Annette are part of a much larger organization. They're members of the American Society for Quality. And the American Society for Quality is, I think it's 85,000 strong membership, about 4,000 individuals that are focused on healthcare quality. And these are individuals who are steeped in traditional process improvement and engineering, but also are focused on healthcare. And so it's a positive thing to be to have that participation, that collaboration with the American Society for Quality as well. Okay.
Just as a follow-up, for the second session, we did have them on site. We actually let them come into the office. We shared our coffee and our snacks, and it was good.
And I got a receipt.
Yes. Got to use the bathroom and everything.
Okay. All right. This is an interesting one. This is for the entire panel. Can you give specific suggestions to help prevent denials for the upcoming August program education? Actually, it starts in October, but it goes back to August. What do you think?
Yeah, that's it.
Oh, I can. You want me to answer this? Yes. Look at CR 9189. Map the specific design requirements in that CR to your process. If you have a gap, fill it. And there's no easier, it's just the way it is. They got design requirements, and then you have processes that have to take that into account. Would you agree? Yeah. But one of the things, let me add to that, because I think when you have this collaborative way of looking at it, so as opposed to, say, you could say in the older way of looking at it, right, you have a stack of papers on your desk. These are the new requirements, right? And typically, you would either, if you had them electronically, you send them out and tell your branch managers or your clinicians, these are the new requirements, implement them. But in the same way that the pilots went through, what is my current state? Go through the process of how do you do business now? How do you collect the referral information? How do you collect the admission order? How do you collect the face-to-face information and the certification information? And who's accountable for it? So in addition to understanding what the design requirements are, assign responsibilities for that so that you know, and also and attach metrics to that. You heard some of our pilots say, we established that the cycle time would be 4 days or 14 days. Right? Because if you don't assign a metric to it and you don't follow that metric, then you may end up waiting until you get denials to know that something's not right. Okay, this one, I guess it's for anybody. How do you get hospitalists to identify the physician that will follow for home health services?
For us at Carolinas, we have case managers and transition liaisons, so we rely on them heavily. And we actually have just recently changed what we call our post-acute referral, our POWER form, and made it a requirement on that form that whoever is following the patient, instead of a PCP, because it may not be the same thing, it has to be filled out. It's actually part of our referral. So that actually will help any agency in our area that will be using that use the form, but it's really the case managers and the transition liaisons on the floors, because the hospitalists really have no idea what's going on in the post-acute world at all.
Do you have a metric on that? What percentage of the time they actually play out and have it identified?
The form actually just went live Tuesday. So we had actually been working with case managers, transition liaisons, our HME, our intake department, and we all got together to completely revamp this form, got rid of what was junk, added what we needed, things that we really wanted, explained why we needed it. And so now that we've gone through a few changes of things that weren't working, and we, of course, had IS involved. Now we are actually going to start doing metrics, and we're going to review them. And if they're not right the first time, we know who wrote the form. We're going back to those people.
So I would just add, things are changing. So we've had 2 recent interactions with large hospitalist groups participating in Model 2 BPCI programs. When we talked about the process for referrals to home health care, they actually ask us the question, can we be involved in following the patient once they go home? Because now they're very interested because they're part of the shared savings program. So things are changing, and I hope we continue to see that change. But to have hospitalist groups say, we'd really like to know what's happening once they're in the post-acute care environment is exciting. And so our answer was, sure, we'd love to have you.
Okay, and I guess I could try to stab at it, but I'm interested in what you all think about this one. What denial rate is achievable related to face-to-face, and why? That's an unstructured question if I ever heard one.
So the current denial rate, or what we have standing, is 50%?
Yeah. And that's overall. Yeah.
Overall, 50% for face-to-face, or that's for all? Don't we've got to get to a point where it's less than 20%, right? I mean, we've got to get there. So I hope that less than 20% is very achievable. I hope we see that soon. Otherwise, we haven't fixed anything.
Okay.
I'm going to put Harry on the spot a little bit, because I think that one of the things that we went into the process feeling, and I don't know that any of us, well, it would be wrong for me to assume that I can speak for all of us in home health. But I think that the part of the question is that as a home health provider, we do feel somewhat helpless in what would be an appropriate denial rate. I think that operationally there's a lot of things that we can do and need to do in terms of our mapping and making sure we've reduced a lot of the waste. I think that we've seen through the projects that we have done that when we're working with our physicians, we've found that there's a willing group of people out there that if we make it easy for them and provide them with the education, they're willing to do it. I think that for those of us who have worked with Palmetto in this process, that there is a belief that we're all in this together and we want it to be right. I will honestly say that there is still a hesitation that we don't know what we don't know yet. And so we don't know what the review process is going to bring about. So we are still, and that I believe that I can educate my physicians in the way that I think it's supposed to be now with new knowledge. And I believe that our organization is in the process of making significant changes so that what we believe is good ends up on the claim or ends up there available should we get requested. I think that until we go through that process of review, we're not yet sure what would be inappropriate. Because in a perfect world, it would be less than 10%. And I think that we would all like to get it to be less than 10%, that we all were working to that. But
I think part of the stated purpose of the final rule was to make it easier on home health agencies and physicians to be compliant, right? I didn't misread that, right?
The CR?
Well, the rule, our 2015, when they changed the face-to-face rule,
Yes.
part of the stated purpose was to make it easier on home health agencies and physicians. So
Less burdensome.
less burdensome. Thank you, sir. So if we don't significantly see a significantly lower rate after the rule implementation and this probe and educate, then I think we've missed something. So I think it has to be pretty significant. 50% is certainly not acceptable, and none of us in the room think it's actually reflecting what we're doing for the Medicare system. And so I think it has to be significant. So I'll change my 20% to 10 to match Kimber.
Okay, so let's flip the question around, because I think this kind of took me to a question that I had for the panel. So assuming whether 10%, which I think is reasonable and where CMS wants us to be, is to go, what's the messaging we should take back, either based on the pilot programs or from the provider community? We know what the ruling has come from the mountain up top. I know there's been some consternation about that. But as you all operationalize and try to execute to that, what's the feedback you would want the home health max? Because part of the challenge when you talk about reviewing is the home health max have to also be consistent in reviewing that documentation. The quicks have to be consistent. The cert contractor has to be consistent. And that's some of the messaging we've already provided to CMS. But what further would you have us try to communicate up to CMS on your behalf, given what you've all experienced? And it's a loaded gun question. I probably regret asking it already.
Well, the problem is it's being recorded.
But I'm waiting to hear your thoughts.
If my boss were here, the executive director of our agency, he would say he would expect 0 denials for face-to-face. That's kind of the culture that we have, because if a patient is legitimately eligible for home care services and we are clear on what the documentation expectation is, why should there be any denials unless we drop the ball in obtaining the documentation? I mean, one episode, we count to survive. We count on payment for every episode we provide care for. We don't plan on in our budget that, we're going to get denied because we're not doing the right thing. We just try to do the right thing. That's kind of been our culture. Same thing with Joint Commission. We expect 0 deficiencies, which, by the way, we had our survey 2 weeks ago and we had 0 RFIs. So proud to say.
I love loaded questions. I think that certainly consistency. I hear it sitting on the board of the North Carolina Association and participating in some other events is that there are times when we really don't understand why what looks the same to us, one was denied and one was not. And so I think it's consistency in that review and consistency across the MACs is so critical. And to have that consistency, I think it requires clarity. I love the fact, if we really want to reduce fraud and abuse, and I think everybody in this room does, they wouldn't be here if they didn't want to do that. We have to close the gap a little bit, because that non-clear allows people who are not going to do it right to walk through that. And those of us who do it correctly or try to do it correctly spend a lot of time and money trying to do it right. And so I think we need more clarity, and we need to ask for that more clear definition of what it is that that is expected of us. And finally, for me, is I want to know sooner. I can fix things if I know sooner. So feedback is incredibly important to us. And I think for me, those are the three.
For providers, I think when they check denied, but the providers say, but we don't know why it was denied. That's part of the confusion for providers.
Well, Jane, let me address that, because one of the unique features that Palmetto DBA has in its medical review system is the ability to identify the granular reason. And with this CR 9189 coming out, we have a checklist, a review checklist that has been computerized, and are going to be putting out letters with specific issues that were missing. And this will serve as a template for process improvement. And I believe that that combination of our being willing to collaborate, providing specific information when denials are issued, will help. To Kimber's point, I personally work very closely with our medical review area. We're going to have in-services way in advance of that October 1st, and going through that CR, and the same process that I described before, looking at each of the design requirements that CMS has in its change request for medical review. That's the exact process that we're going to use. So that when we develop or when we review a record based on the design requirements in that CR, we can point specifically to the areas. Yes, ma'am.
I have a question and a comment both related to this topic. The rule became effective January 1. Up until May, we had no real clarification from CMS. They were working on the template and the provider conferences that happened. And then now we are getting into October, and we are still not really clear exactly what is expected. We have seen the CR, and we know you're going to do probe and audit, but the time from January to October or August the 1st will be exempt from future audits by a RAC auditor, or?
I wouldn't go that far.
Nice try, Joe. Okay.
Well, see, what I'm trying to say is you're expecting 0% error rate, but CMS put the rule out without clarification, and we are halfway through the year, we still don't have clarification. So if the auditors don't have clarification and the providers don't have clarification, and CMS doesn't have clarification, how are we expected to do the right thing? Because we are here because we want to do the right thing.
Yeah, if I could, just for the sake of the record, the question was essentially, since the rule that withdrew the narrative requirement went to effect January 1, the perception is that there has been less than complete clarification of that aspect, and how in the new normal, what's expected. How are you to implement? Well, I think we were all waiting for this medical review CR to come out. So now that it is out, and because they're, for the sake of the probe and educate aspect of it, they're not going to go back before August 1st, right? It's going to be focused on August 1st forward. That's the way that CMS is handling that. Now, as for the recovery auditor and CERT and all those others, they have their own directives that they follow. But in terms of ABMAC and Probe and Educate, we won't go back to look at, the Probe and Educate won't be part of anything before August 1st.
Harriet, can I just add anything?
Ed's question involves messages of CMS.
The question is, does anyone want to comment on Ed Sanchez's question? What should we be communicating to CMS in terms of your expectation for going forward?
I mean, Kimber answered.
Yes.
Chris, anybody else?
I think what Kimber said was very important. And secondly, because I have experience in acute care and now home care and a little bit of hospice, other things seem more clear regulatory wise than this whole home care face-to-face initiative. And for hospitals, it's extremely confusing. And so they're wanting to push those patients out sooner, and they don't want the readmissions to be high. But if home cares continue to get the high amount of denials that, I mean, it sounds like everybody's experiencing, I mean, it's just a negative effect. And then eventually it'll ripple down to where you disable, essentially, the home care agencies to be able to care for those patients, because we're doing a lot of rework just to try to get it. Where the root is they don't understand a lot of other regulatory things are standardized, and everybody knows what to do, and it's well educated, whether it be a physician certification for skilled care or what have you. In South Carolina, they're a little bit more defined, but this face-to-face, when we're talking to them about that, or even home care certification, that seems to be the mystery. And Dr. Snipes is doing a good job of educating, but I can't imagine that would be centralized to Spartanburg. And I think that's going to be, we have found that it's very prohibitive to patient referrals or in our area, because physicians just do not want to go through the steps of trying to complete it, because it's confusing to them. And when we're sending things back, they are shredding them, and we're doing all we can to educate them, but there's a lot of money tied up where we're not able to take care of the patients in the same way that we really want to, and focus those efforts on increasing quality, which is ironic because we're all moving to value-based, but we're chasing something else.
Which in the end, it seems to me that what you're really saying is, in the end, we need you to go back to CMS and tell them to forget about homebound status altogether, and let us really focus on caring for those patients in the long run to keep them out of the hospital.
And for the sake of the round, I'll paraphrase it. The comment was, because we're going towards a value-based environment, let's decrease the restrictions in terms of the strict homebound and all the other, and go on outcomes and process.
So I guess I'd jump in the chopping block too, and just say, as far as the message back to CMS, for me, it would just be about the process. So if 50% of the claims are denied, that tells me there's a problem with the process and the language of the rules that we're surveying for. And so I think if this probe and educate round goes as I suspect, I don't think there's going to be a significant decrease in the denial rate. I think it'll be about the same. I think that CMS should be prepared to start over and should be open to the process is still not where it needs to be. And so we need to go back and redefine this concept. And related to the homebound requirement, CCJR, if you've read that proposed rule, they talk about that a lot. They really considered removing the homebound requirement for home care agencies and then decided, we'll leave it, but we'll let you do some of these nursing visits incident to physician services. And so we all need to go comment on this rule and explain the value of removing that requirement, because that's what it's going to take. And so I feel like momentum is getting there. But that would be my message back to CMS is, we tried once, that didn't work. Now you redefined it. We'll see how that works, but be prepared to redefine it again. And next time, do what Palmetto did, which is come see us. We invite congressmen to come do home visits with us all the time, and they never want to come. They want to come get the pictures. They never want to go into people's homes. But it was refreshing to have Palmetto come and visit an agency and see what we do live. And so I would just love for CMS to come and just ride along with our clinicians and see what home care is all about, and then walk through the processes with us and talk with physicians directly and let that influence the rulemaking. I think that would change their perspective a little bit.
Does the word chicken mean anything?
There
This
was,
is killing me. This is getting taped.
there was one question that really is dovetailed to what we were just discussing, and I'll take it on first. It's what's your advice on best way to roll out changes across, it said region, but I'm going to add an S to it. Because in this room, we have not only Palmetto GBA, but also the representatives from the other home health MACs. And I would imagine that after hearing the presentations and viewing the maps and understanding the process that we went through, that they'd be interested in leveraging that knowledge. So as we roll this forward and as we work collaboratively, not only with our providers in jurisdiction M, as of August 27th, we've changed from J11 to JM, we're also going to be working very closely with the other MACs, the other home health MACs, and by the way, the AB MACs. Because say in a state like Florida, where we don't have the AB work, but we have the home health work, we work with the AB MAC that pays the physician claims in Florida to work this process in. And same thing in Texas and the other states that we have home health responsibilities for, but not the AB MAC work. Okay.
Can I go back on just one of the questions? I'll do this.
So I just wanted to come back to this question that was asked, if we're at a 50% denial rate, what can we get it down to? And I think it's probably better than the 20, although it's not in one leap. And so one of the things, and Chris, I admire the goal, but one of the things that we talked to each one of the 5 pilots about is there is no perfect process. And Kathy and I can calculate this for everybody. One of the things we needed, and I think we talked about in the beginning, was getting everybody to start measuring the process. So let me just step out of the home health for a moment and give you an example. So if you're using what Kathy and I do, Lean and Lean Six Sigma, we're able to calculate some of the possibilities here. So let me just give you an example of Six Sigma and what it means in the improvement curve. So you're really looking at the number of defects per million. That's what you're measuring. So let's say, what's the thing that we all just love about our phone and our phone service? Can I hear you now, and do I have a dropped call? So let me just give you an example. If you had 7,000 talk minutes and you were at a 1 sigma rate, you would drop 4,839 calls. To move to a 3 sigma rate, any idea what that number would be? Ballpark? You go all the way down to 467. To get to 6 sigma, which is what I heard a couple of people talk about, you'd be down to 0.02. So we're not looking for perfection in the process, but we're looking for huge improvement. And there is opportunity to do that. And I think particularly in Bud's presentation, when you were going through the metrics, you'll notice that they had goal numbers. So they had, here's where I'm performing, here's my goal number, and here's our target. And that was a lot of the discussion that Kathy and I pushed. Let's have a goal here, but let's figure out how we step our way to getting a better performance. So I think it's better than 20%, and we can calculate that for you. But 0%, it's never going to be achievable, just to let you know. So there is reality within the whole process.
All right, this is a more pragmatic question. Any ideas on how to get EHR vendors to accelerate or accept revised templates?
Go ahead, Lila.
I think Chris and Bud probably talked about this in their presentation. One of the challenges that I think we all face is and it goes back to Max doing things a little differently, is that EHR vendors are trying to serve a nation of providers. And there are two things there. If there is not consistency among the MACs, then we can't convince our vendors that it needs to be done this way, because one's interpreting it this way and another's interpreting it another way. So, that would help us a ton just from that standpoint. They'd be able to respond and react faster if they knew that this is the one way it's to be done. I think the other thing is the onus is on us as home care providers. We have tended, I've been in this business now for I didn't start with gray hair, okay? So I've been here a long time. And we have tended not to adapt and adopt evidence-based or standard practices. We generally don't like them. We still have clinicians out there, and you do too, who like to do it the way they've always done it, regardless of the fact that they have absolutely no evidence to the fact that it works. It worked once with a patient that they were having trouble with, and so they've stuck with it forever. And I think we have an onus to step up to the plate and say, we're going to be big players in this new healthcare world. And for us to be big players, we need to be talking to the other people in the same way that they are operating. The hospitals are operating with evidence-based protocols. The vendors are trying to standardize practices. Lean is in a lot of different places, and people are looking at processes and practices. And I think we as an industry have to take some ownership in that and say, okay, it may not be the way we've always done it or the way we like it in our agency, but is it the best way to do it? And are we going to be able to change some of our processes so that we can standardize things and be willing to do that? So it's not just you I yell at, Ed. I yell at us too.
So as far as getting the vendors to respond quicker to changes, what's worked for us is strong user groups, because I can put in requests all day long, and if they only hear it from me, it may not pop up on their radar. But if I start contacting other agencies that use our same vendor and say, hey, what do you think about this? Oh, that's a great idea. I'm like, well, you also put in that request. And we've done that in the past through user groups. We've established regional user group for Delta, and we've gotten agencies together quarterly on conference calls, talked about what improvements we want to see, and prioritize them, and then provided that prioritized list to the vendor, so to kind of help them get started on what they should be working on.
Okay. All right, there's a question. All right. What is the best process to review home health records for compliance and payment for the most recent face-to-face regs? And I think we went through that a little bit already, to adhere to the CR. And I guess I want to ask the process engineers, because in that question, there was an element of inspection. I thought I heard inspection in here.
My recommendation is to first figure out what your people are doing. And that's what we found out when we went out to the pilots, that everybody thinks they know what the rule says. And they think that they're complying to the rule, but you have to find out what's really going on and find out where those pinch points are at. Because, for instance, face-to-face, you might have a face-to-face document that you think meets the mustard, but it doesn't. So, you know, look at how you're delivering your documents, figure out where the defects are or where it's lacking. And then don't try and solve it all at once. Take it piece by piece. And that's what these people are doing. We left them with a stack of initiatives, and we said, okay, prioritize. And figure out where you want to attack the problem first. And then start working that, and your big heap of problems will slowly start to go down. So relative to the new rule, and I think we talked a little bit about in our presentations, you know, what is being expected of a home health claim. But you need to figure out what your people are doing. And that's really the key critical part. Once you know that, and don't rely on a training manual, because that may not be what your people are doing. And also measure, measure, measure. Always look, you know, put some key measures in place in the process so that you can start determining what is a clean claim at intake. Don't wait until it hits the billing wall. Go way up front in the process and see what's actually coming in. I know that there were some surprises here in Shands. The first time you started measuring your process, it was someplace around, I think, like 7% clean claims or clean referrals. And then it jumped up to 14. But, you know, just start measuring those points in the process where you know you're getting inadequate information to meet the rule, what the rule is asking for. So that's my advice, and that's what these folks have been doing here as they discovered, that's what these big walls are over here. What are their people doing? Because that's really key. Did that answer the question?
Okay. All right, and this one, I'll answer, but I'm interested in knowing your take on this as well. What should we do if we suspect that one of our competitors is not following the rules? From a Palmetto GBA perspective, there are several things you could do. The first is obviously pick up the phone and let us know. The other is you can call OIG directly, or you can go online. If you go to the OIG website, and it will ask you whether you are an HHS employee or not, and then it will walk you through how to report a suspicion. But for more practical advice, I'll turn to the panel.
So I've reported agencies taking those steps before. But one thing I would recommend, which we also did, is to reach out to those agencies and say, hey, here's what we understand is happening. Can you confirm if you're doing this or not? And let me explain why this is a problem. So I think we do owe it to each other to reach out professionally and talk about it, because there may be a misinformation problem. There may be a lack of education that you can help resolve. So I have reported agencies for other egregious things, but always reach out and say, hey, this is something I'm hearing and it's not good. Let's talk about it.
I just want to kind of support what Bud said. I have done that as well, and always call them. And I think that sometimes we think that because of the size of the organization, that perhaps that it is an intentional, that they should know better. But some of the larger operations, they may have rogue branches that may be in your area. And it may not be part of that company. It may be that particular branch. And so it's always good, because if they are a rogue agency, just that call can sometimes stop that behavior pretty darn fast.
Okay. This question is one that I can address. It asks, if hospital physicians complete face-to-face encounter and certifies home health, so the hospitalist is doing both the face-to-face and the certification, and hands off to the community physician, is it CMS PGBA expectation to see documentation from the hospital MD he notified the community physician? And the answer to that is that in the benefit policy manual, it simply says that you have to identify who the following physician is. So does that answer your question, whoever asked that? I hope it did. It's just an identification on the certification or on the accompanying information. There always has to be a following physician. That's part of the certification. So if you're not going to do the plan of care and follow them, you have to identify somebody if you're going to certify.
So can I ask a question about that?
Sure.
If a hospitalist had the face-to-face encounter and the primary care physician signed the plan of care, he's overseeing that, and he signs the face-to-face encounter, the plan of care, the physician that signed the plan of care, saying he reviewed it, then that would indicate that he's following, right? It wouldn't necessarily have to say Dr. So-and-so is following on that?
There has to simply be evidence that they're, because what in that statement, the presumption, I'm reading into it, but you tell me if I'm wrong, that in addition to doing the plan of care, they're doing the certification as well. Or who's doing the certification?
Well, and I think that maybe that's just my confusion, but where is the certification just with the face-to-face?
Okay, let me address that, because that's actually the three-box diagram that we show. And language is important, right? And if you conceptualize it in the following way, that the face-to-face has to occur 90 days before or 30 days after the certification, right? So it is not the certification itself, it's just the face-to-face or the encounter that the certifying physician will use to make the statement or check that box when they go to certify. Because if you look at the benefit policy manual, there are specific components of the certification, and I guess you are certifying that a face-to-face did occur and the date. That's part of the certification for home health. So the face-to-face in and of itself is not the certification.
So if it's two different physicians, that one that signs the plan of care and one that has the face-to-face encounter,
Yes.
completes that, which one certifies?
The certifying physician.
Is the one that signed the plan of care?
Well, it depends on the form that you're using. Some organizations have a form that includes the plan of care and the certification.
Right.
Right?
Right.
Whereas, and Paddle, you can help me out here, there are other organizations that may have a separate statement, because there's no requirement that you use a specific form, even though there is a form 485.
Right.
Let me talk about 485, because initially when we engaged with the pilots and even with the physicians in the OPICP, we would hear back, well, that individual, signs the 485. So I would ask the question, well, do you mean the CMS form 485, the plan of care certification? And they said, no, the plan of care. So I was saying, so who's certifying? So it's almost like the Abbott and Costello, who's on first? So you have to ask yourself the question, what form are we actually talking about, and what are the components of the form? Face-to-face is a separate and distinct component that's required for certification, but it is not the certification in and of itself.
But if we're using the old 485 format that has the certification language on it, then that physician that signs that plan of care would actually be the one completing the certification.
Correct, because it'll all be on one form.
Gotcha, okay.
And they would have to still identify the date of the encounter, the face-to-face encounter, and have that note in case someone asks for it.
So, Carrie, that was slide 33 that you might refer to on the 2 by diagram.
Oh, okay.
You can just mention
Oh,
something.
okay.
Look up and that way helps the diagram.
And that is reminding me that was slide 33 in the handout. It's a 3-box diagram. But it's an important question because sequence matters, right?
Yes.
And what we found with, especially with the physician pilots, was that they weren't all understanding that, you know what, the hospitalist can do the face-to-face and certification. They can do that. What really is important, though, is that, and CMS says this, is that if one physician is going to do the entire thing, you would expect that the plan of care and certification be signed, almost together because one person's doing it. We could see, and I think in the manual it says on rare occasions that the certification isn't signed, is signed as soon as possible, I think, or as soon as practicable, something like that. The manual says that you would want the certification signed, but definitely before billing, right? Because you can't bill for it. Okay.
So you mentioned the certifying physician is to certify the date of the face-to-face encounter. I'm sorry. So you mentioned they have to certify the date of the face-to-face encounter.
They have to include it, yeah.
So can that be documented? So can you talk to form? Because I think that's a question that you're going to have next. Does it have to be on the same form? Can it be on a separate form? So there's no structured or specified format, correct?
That's correct. As long as the certifying physician is communicating when that face-to-face encounter occurred, that's the requirement.
And so if the home health agency has a separate form, can they capture the date of the face-to-face encounter, the date that it occurred, for the certifying physician to sign and then authenticate and incorporate into the record? So can the agency document that date?
Well, I'm going to ask you this. Does the agency have the physician note?
Yes.
And they're going to give that physician note to the certifying physician?
Yes.
Okay, so then the physician can corroborate that the face-to-face occurred on that date.
So there's still, and you guys tell me if I'm just nuts, which is probably a yes. But I think there is still a tremendous amount of confusion in the industry, in our industry, about who can and can't write that date, the date that the encounter occurred, because there's been some official language that came out that said no, only the physician can document that, or the physician's staff. And the CR actually says the certifying physician must document. But then there's been, and I've had communication from CMS saying that yes, the home health agency can write it and the physician can sign it, and that meets the requirement. So I'm nervous about guidance to the MACs about medical review, because now that I have that in writing, that's what we're going to attempt to do. Because to ask the physicians to write that date into a form, I'm afraid is going to be a great challenge.
Well, when we see I'll go back and speak to our medical review staff, but when we see the record, what we're going to see is that there is a face-to-face encounter, that the physician has identified that this is the date of the encounter. It's part of the physician information. So I don't know that we could, how would we know who wrote it in, who wrote that date in?
Oh, yeah. So So that there will be different handwriting for sure, but I think that is still a concern in our industry is who can document what.
You know, what you said, you mentioned, but that you had official response from, is it CMS?
Mm-hmm.
Okay, then you would expect that they wouldn't find you out of place to share that?
Right. I'm hopeful. I'm hopeful. I think that's just, there's still some unfinished business in the rule, and the CR clarifying it 10 days before, or I guess 20 days before the amazingly sounding probe and educate just leaves us all leery. It just leaves us all nervous that we're going to miss something. None of us wants to miss anything.
Yeah. Well, I think unless medical review has another view of it, if we have the date of the encounter, the note, and the physician's acknowledgement and certification and the face-to-face and everything else is hunky-dory, I don't know that we would ask if I don't know how we could tell. We couldn't. All right. Next question is, could Palmetto GBA collaborate with healthcare providers and CMS to provide physician CEUs? And could we? This is an interesting question because one of our contracts, Palmetto GBA has the contract for what's called Train the Trainer. I don't know if you are familiar with this contract, and we develop education for CMS. And I know that as part of that contract, there are CEUs that are applied for. So what I'll do is I'll go back and speak to the folks that are over that contract and ask them what their process is. And if Palmetto GBA can help, we'll evaluate that. But as I mentioned before, it's always best to have a partner in the state where we are providing education, because there are nuances to, talk about jumping through hoops, right? All the paperwork and et cetera that needs to occur in order to be issued the CEUs. So while I'll take that as an action item to go back and ask about our trainer process, what I'd like is of the organizations, the state associations in the room, if there are central, organizations, educational organizations that you work with in the state, if you can let us know, and then that will allow us to, if we're considering CEUs in that particular state, allow us to work with that organization and develop CEUs. I thought that Dr. Stipe's presentation and his acknowledgement that CEUs are going to be a draw for the physicians is an important thing to investigate and to see.
So are you talking about CME only, or all CEUs with all provider settings?
Well, that's an excellent point, because the concepts that we're talking about, for example, APTA, the American Physical Therapy Association, they've incorporated ICF into their practice guidelines.
Right.
So have the occupational therapists. So have the speech language pathologists. Okay. So that's a good point. That at least first blush, let's keep it broad. Broaden it out and say not cut off any particular discipline. Okay. But we're going to need help to identify it. And I'm sure that Bud's probably sending a tweet to one of APTA folks right now. Palmetto says they need help.
Well, but the reason I ask, so from our state association perspective, we have agreements with the other disciplines within our state to provide those hours when we do our educational promotion. So how do we get that information to you?
Well, you can send it out. Well, you have my email address at the end of the...
I have Marilyn's. Can I just send it to her?
Well, you can send it to Provider Outreach Education. Okay. I mean, that's our central location for education, sure.
Gary, how about just one more question?
Okay.
One more for the panel.
Okay. One more question, so I gotta make this a good one, huh? All right. I'm gonna throw this softball out here, I think. What else do you suggest Palmetto, GBA, and CMS could do better to understand home health?
I'll go first again. So I would say, continue to engage the providers directly on site and come right along with us and see what these patients are like, see what our clinicians are like, and see what we're really doing out there. Meet with the physicians. The more on site you are, the more you'll know about what we do. And I think the better the LCDs will be, and the better the policies will be that come down from CMS.
I agree. I don't know how not to talk.
I went to Catholic school. Someone asks a question, I feel compelled to answer. I don't know what else to do. I agree, and I think that not only is it seeing our patients and going out into the home, but I think that CMS and Palmetto may not always understand the administrative burden that they put on us. What seems like a really great idea, we have to put, it may be another FTE, it may be another 14 pieces of paper. The administrative burden is huge, and all that does is raise our costs. We're not adding any more clinicians, and our costs keep getting raised. And I'd rather spend money on another nurse.
I'm not sure how I want to say this, but having face-to-face documentation in the chart doesn't help us take care of the patient. It helps justify that the patient qualifies for home health services, but it doesn't add to the quality of care that we're giving.
Okay, no other takers? Okay. Well, today has been a very knowledge-filled day. I mean, I think that we've had an opportunity to hear some very unique stories with common theme, which, based on the nodding of heads in agreement, you're also experiencing. And as the Home Health AV MAC, specifically the JM MAC, we're hoping that as we enter the next phase of this contract for JM, that you'll see us as partners, as true partners, and work with us on collaborative efforts like this that we will be undertaking. We want to continue to bust the myths. And I want to thank the participants, the pilots. They did a fantastic job. We give them a round of applause. I want to thank the process engineers, Kathy and Annette, for their help. And I also want to thank you for taking time from your busy schedules to be here. And I hope this was worthwhile. And if it was, please share this information. When we send out the slides, please share the slides. And please follow us on social media. Thank you. Oh, and there's an evaluation form. There's a QR code here that if you use your smartphone, you can answer a couple of questions about the event, and it'll help us to improve future events. Thanks.